We can also start thinking, let's go upstream. Why are we trying to treat the problem after it occurs? Why aren't we trying to figure out how to prevent it from in the first place? So we ought to be thinking about what can we actually do in the hospital, not just on the day of discharge, but prior to that to try to prevent, to address those root causes. Now, if you think about, what's happening in the hospital? I mean, some people may be coming back to the hospital for something completely unrelated to their admission in the hospital. You know, so hard to imagine what you would do in the hospital to prevent that. They get in the car accident, they come back. But they might be getting something that actually is an error of commission on the part of the hospital. They get an infection. But there also may be something, like my case of the woman with the UTI, some problem that got treated but didn't get resolved. And then there's also the post-acute care transition process. So when we looked at this in Pennsylvania, and a lot of this is based on, as Mylea mentioned, I've actually organized and ran a project in Pittsburgh area focusing on reducing readmissions for COPD patients. But we looked more broadly at the data. So this is data from Western Pennsylvania back in 2007. And you don't need to read this, but this is a whole series of diagnoses and the readmission rates, some high, some low, but on average 18%. But we looked and said, how many of them are due to some complication or infection related to their hospital stay? About a quarter were. Not a trivial number, so that could be something that could be addressed, but the majority were not. But the hospital doesn't necessarily have to intervene only in the things that it's causing itself. It may be able to do something to improve the way care is being delivered for the patient in general. So for example, can you transition the patient to their post-discharge medications earlier? We found, for example, that most COPD patients are on a handheld inhaler in the community, but while they're in the hospital, they're on a nebulizer. And the day they get discharged, you know, here's your prescription for your handheld inhaler. Nobody actually watched or taught you in the hospital how to do that. So can we do better patient education during their stay, not just on the day of discharge? Can we actually, if they're not taking their medications because of some problem, can we test some alternatives and see what might work? And in general, can you think about how to use physical therapy, OT, patient education to help deal with what kinds of challenges the patient may be facing whenever they go back to their home and community? We could even go a little bit further upstream and say, when the patient typically comes to the ER first, do they need to be admitted, or is there something that we can actually do in the ER to try to deal with that? So for example, I've always found this to be an odd term, the asthma lounge. This is a hospital in California created an asthma lounge, and basically the idea was that when you come into the ER with an asthma exacerbation, rather than admitting you or sending you home as your only two choices, they have a third option, which says, we'll send the patients over to a special area where we can actually try to do some more intensive intervention, and then we'll do some follow-up from there. Why wait to admit them and then go to discharge? Let's figure out what we can do in terms of better discharge follow-up following the ER. And they've seen everybody's happy. Fewer patients admitted, the patients are happier, and you've saved a lot of money through this. So things can be done at the ER level. And truthfully, we should be going way upstream. As Mylea said earlier, the goal is not just to reduce readmissions. Why are we waiting till somebody goes to the hospital to do something for them? We should be thinking about what we can actually do for them proactively on a preventive mode to keep them from ever even getting into that situation. And that's really where you can try to build on the patient-centered medical home concept. And lots of studies show that you can actually make pretty dramatic impacts, not just on readmissions, but on admissions and ER visits. Not little itsy-bitsy statistically significant changes, but 30, 40, 60% reductions in hospital admissions by very simple things. Patient education, self-management support, things like telemonitoring, et cetera. So if you think about this, what's the comprehensive approach to doing this? It says we should be trying to identify where all along the continuum there are opportunities to try to intervene and try to fix the problem there. Starting with the patient's primary care in the community, and then, if problems happen, trying to intervene as early as possible and having a complete wraparound solution. So the transitional support is certainly desirable to deal with transitions, but we've got to have a more comprehensive solution, in my opinion, if we're going to be able to make this work. So for example, in Pittsburgh, the project that we created, we tried to deal with a more comprehensive approach. As we looked at it, what we saw was that when COPD patients were going into the hospital's approach was treat their exacerbation and get them out the door as quickly as possible. And then when they got to the community, nobody saw them. Only if the patient actually pursued a PCP visit did they get seen. And if they had a problem, what was the answer? Call 911, go to the ER. So we tried to figure out how to improve patient education and the discharge and transition process, yes, but we also said, what can we do in the hospital to try to address the root causes that are bringing these patients in through better medication skills, smoking cessation, et cetera. What can we do to try to boost the way the primary care system is supporting them by having a nurse care manager, by helping them make sure that they can get access to their medications, getting prompt follow-up immediately after discharge, not 6 weeks. A funny story, at the hospital, the one hospital where we did this, a pulmonologist put together a set of guidelines to try to advise what should be done. And wrote up a lot of things in terms of medications, and then said patients should see primary care physician in 6 weeks. And we said, well, doctor, you know, it's 30-day readmissions. Oh, right. Okay. So all of a sudden it was 7 days after discharge they should see their PCP. Instead of having the ER used as a solution to the problem, we said, what can we do to make sure that we have prompt response to exacerbations when they occur and encourage the patient to call early? Many of the patients were saying, oh, you know, if I'm feeling a little short of breath, I don't want to call the doctor's office. I'm bugging them all the time. So you had to say to the patient, no, good, call. Yes, please, we want you to call. Call early, call right away. You're not bothering us. And then, of course, we also had to say, so in the physician practice, are you going to be able and ready to actually answer the phone when the patient calls and do something for them in a timely fashion? So the idea was to be able to reduce readmissions. But the fundamental idea we had was, how do you actually flip this around and put community care first and say, what are we trying to do to improve that so that we keep them from going to the hospital in the first place, as well as going back to the hospital if they end up being hospitalized. And information about this is on these websites, and I'll make this presentation available since I'm a bit of a last-minute Charlie on this and just finished this an hour before the meeting. So anyways, this is all written up in a guide that you can get on the web. But if you look at what we did in Pittsburgh and you look at what's happening in various projects around the country on trying to reduce readmissions, there's some pretty common standard elements. How do we get multiple providers to coordinate better? How do we educate the patients about their condition and what to do to better manage it? How can we give them some supports to do better self-management, not just education, but what kind of help do you need? Are you having trouble affording your medications? What can we do to help you? Having good reactive interventions so that we actually can react quickly if a patient has a problem early, but also proactive interventions. What can we do to actually go out and try to identify things before they happen? And that typically requires going and seeing the patient in their own home or setting to be able to figure out what the problems are. I've often told the story about, we had one patient who had been admitted to the hospital twice in the past year with Pseudomonas pneumonia. When the nurse care manager went to the home, she found that the patient was, he was using a nebulizer and had been dutifully every day washing his nebulizer as he had been instructed, and then putting it wet into a plastic bag and sealing it up. Wonderful breeding ground for Pseudomonas. Now, the patient had gotten education and thought he was being adherent, but nobody had ever actually watched what he was doing to say, you know, you didn't get that quite right. You know, this little adaptation you made doesn't work. Now, the thing I'm a bit concerned about is everybody's now starting to work on readmission reduction. And if you think about the patient-centered approach, so what's going to happen to the patient whenever they have 7 different care managers all calling them up, saying, what can I do to try to improve your care? And if we really want to be patient-centered, we have to think about how is this going to work from the patient's perspective in all this. So how do we get all that coordinated? Well, answer is probably everybody should work for the same corporation, right? Yeah, right, we know how well that works, even those of you who all do work for the same corporation. Option 2, though, and the more realistic option, is that we figure out a way for the different people in different settings to actually coordinate with each other. How would we do that? Well, I would say you need to have at least 4 things. First of all, you have to have some kind of be driven by data. So analyze the data and say, where are the problems occurring? We need to know where the problems are really occurring, not just, hey, we're going to dive in with a readmission reduction initiative. You got to have mechanisms to coordinate multiple programs. You got to have some kind of information exchange about the individual patients. So who is doing what to them, and are we actually coordinating? And then get real-time feedback on performance. How would you do that? Well, first of all, it really helps if you have some kind of a common database of information. If everybody's operating on different data and can't actually pull it together in any systematic fashion, that's a real problem. In the project that we ran in Pittsburgh, it was a huge advantage to us that we had a multi-payer claims database that we could look at. So when we looked at it, we said, this was back before anybody was talking about readmissions, so we said, so where are the readmissions coming from? We looked at the rates. These are, the red is the readmission rate, and this is congestive heart failure, pneumonia, depression, COPD, kidney failure, abnormal heartbeat, diabetes, and asthma, which were the top volume conditions in Western Pennsylvania for readmissions. All of them had high readmission rates, but dramatic differences in terms of the actual number of readmissions. And so if we really wanted to make a big impact, we wanted to focus on not only where there were high rates, but lots of patients. Congestive heart failure was number 1. A number of people were doing things on congestive heart failure. We noticed COPD was number 4 and didn't know of anybody who was working on COPD, but the data let us dig in a little bit more. And when we dug into this, we found that pneumonia, which was number 2, 40% of the pneumonia patients had COPD. Now in the hospital, they were viewed as 2 completely separate things. Patient came in for pneumonia, we treat pneumonia. Patient came in for COPD, we treat COPD. But if you go back and dig in the data, you suddenly discover it's actually the same patient population. It's just that sometimes they end up in the hospital with pneumonia and sometimes they end up with COPD. And so when we said, who are the actual patients, we found that the COPD population was actually the second biggest readmission population. But they weren't necessarily always coded that way in the hospital in a way that you could easily find. And we also found, surprisingly somewhat, that a lot of those COPD patients were not Medicare patients. They were younger patients, and that the readmission rate was actually the same. Quite surprising, the readmission rate was constant for COPD patients across age. So we thought there's a perfect example of something that can be done across all payers, both commercial and Medicaid in the community, and will benefit all patients. So common database helps. You also have to have a neutral convener, which is, I think, exactly what Q Corp is doing here today, is bringing everybody together in a way that they can actually talk about what they're doing and other ways to be able to do it better. Information exchange, health information exchange, and when everybody's on EHR will help, but I think that simply protocols for how we make sure that we're sending information to the people who need it is going to be very important. And you need to get real-time feedback on performance. Real time. Not, last year's data, but we need to know what happened last month or last week. And that's actually a limitation on the claims data side, is it ends up being too slow.